Hi everyone, my name is Naba. Today I'll be presenting my honors research project for abnormal psychology titled Complex-PTSD, an in-depth analysis. I'd like to thank Dr. Laster for the opportunity to explore this topic. Let's get started. So first, we're going to have a brief introduction to what exactly CPTSD or complex PTSD is. According to the ICD-11, CPTSD includes the core symptoms of PTSD, but it also involves disturbances in self-organization, which we call DSO. A nuanced diagnosis like this is crucial for understanding the effects of chronic trauma. Globally, the World Health Organization estimates that about 30% of women experience intimate partner violence, which is a major source of CPTSD. This diagnosis is especially important because chronic trauma doesn't just cause fear, it alters a person's whole self-concept and their ability to trust others. Historically, the ICD-10 included a diagnosis called EPCACE, enduring personality change after catastrophic experience. However, that was kind of vague. In the ICD-11, this evolved into the clearer, clinically usable diagnosis of complex PTSD. This change reflects a major shift in how we understand chronic trauma responses. The refinement from EPCACE to CPTSD reflected the growing recognition that trauma can be profound in its ability to restructure your entire personality, but should be viewed through a trauma-informed lens and not simply as a personality flaw. CPTSD expands upon the traditional PTSD criteria. PTSD involves re-experiencing avoidance and a persistent sense of threat. CPTSD adds 3 key features: affective dysregulation, a negative self-concept, and disturbances in relationships. These extra symptoms really capture the deeper psychological wounds from long-term trauma. And I believe it's affective, as it's dysregulation of a person's affect. PTSD symptoms are often fear-based, things like hypervigilance and avoidance. In contrast, CPTSD symptoms are more internalized. People experience chronic shame, emotional numbing, and a deep mistrust of others. Interestingly, research by Fernandez-Filol, which is one of the peer-reviewed articles that I consulted for this project, and his colleagues, in 2021, found that expressive suppression, which is just another way of saying bottling up emotions, is much more strongly linked to CPTSD than PTSD. Unlike PTSD's fight or flight hyperarousal, CPTSD often leads people to emotionally freeze or shut down, which makes it harder for others and sometimes clinicians even to recognize. Among survivors of intimate partner violence, CPTSD is actually twice as common as PTSD. The same study, Fernandez, Filol, and colleagues found that 39.5% met criteria for CPTSD compared to only 17.9% for PTSD. So that's half, actually less than half. High levels of fear, low resilience, and maladaptive emotion regulation were identified as major risk factors. This really highlights why we need to screen for CPTSD, not just PTSD, especially among intimate partner violence survivors who might otherwise be overlooked. CPTSD is typically caused by chronic interpersonal trauma. My research in this project taught me that interpersonal trauma is much more likely to cause CPTSD than PTSD, which can be characterized by like just like one life event. It's not always just one, but it's for interpersonal traumas like in intimate partner violence and in an abusive relationship between a caregiver and a child. CPTSD is likely. These traumas are prolonged, inescapable, and often occur early in life. Research shows that people with higher trauma loads are more likely to develop CPTSD, not just PTSD. The key pattern here is helplessness. Trauma that is repeated, inescapable, and interpersonal creates deep wounds, and that is quite literally complex and more complex than even single incident traumas. Now let's delve into the psychological and neurological effects. The effects of CPTSD go deep. Neurobiologically, we see dysregulation of the HPA axis, amygdala hyperactivation, and shrinkage of the hippocampus. Psychologically, early maladaptive schemas like feelings of abandonment or defectiveness often develop in response to early neglect. These schema is described by Young and colleagues impair emotional regulation and damage interpersonal relationships. Like these like schemas like I will always be abandoned become deeply ingrained, and they drive maladaptive emotional and relational patterns throughout a victim's life. Here are some comorbid conditions. CPTSD often co-occurs with anxiety, depression, and dissociation. Although it shares symptoms with disorders like borderline personality disorder or BPD, the underlying causes are different. Kulkarni in 2017, this is another study that I referenced, suggested that CPTSD offers a less stigmatizing and more trauma-informed framework for people who might otherwise be misdiagnosed with BPD. BPD is one of the most, if not the most, stigmatized mental health condition, and a lot of mental health resources go towards people with BPD, and the suicide rate for people with BPD is high. Recognizing CPTSD as distinct from BPD can destigmatize clients and guide them towards trauma-focused rather than personality-focused care. Delving a little bit deeper into the differences between BPD and CPTSD, BPD is characterized by affective instability, impulsivity, and an intense fear of abandonment. CPTSD, however, involves chronic shame, avoidance, and a persistently negative self-concept. While BPD often involves a fragmented sense of self, CPTSD involves a coherent but defeated self-image. So it's consistent, but it is often negative. The ICD-11 separates these conditions, but neurobiology hasn't yet clearly differentiated them according to some studies. Opinions on this do differ in the literature. Even though some symptoms overlap, the core issue in BPD is unstable attachment fears, while in CPTSD it's deep-rooted defeat and shame. The clinical implications include that misdiagnosing CPTSD as BPD can lead to mismatched treatment. BPD is usually treated with DBT or dialectical behavior therapy, but CPTSD responds better to schema therapy and acceptance and commitment therapy, or ACT. Dialectical behavior therapy really helps people that have big emotions, and it just isn't the ideal care for people with CPTSD rather than BPD. Matching treatment to the underlying disorder is crucial. Misdiagnosis by a professional can mean years of ineffective care, and this is especially devastating in vulnerable populations. There are also cultural and social barriers to diagnosing CPTSD. Many diagnostic tools are based on Western norms, the WEIRD population, and cultural stigma or language barriers can prevent proper diagnosis. Fernandez-Fillal's research stresses the importance of culturally responsive assessment practices that are different and individualized depending on an individual's culture. Especially for marginalized groups, trauma can be expressed differently through somatic symptoms, silence, or otherwise culturally specific expressions of distress. Based on all this, there are 3 major recommendations that I've come to. First, we need to adopt trauma-informed care universally. Second, clinicians must learn to distinguish CPTSD from other overlapping disorders, especially BPD. Third, we should integrate cultural humility and cultural I guess cultural understanding is what I'm trying to say, into diagnosis and treatment. A trauma-informed approach doesn't just change treatment plans. It transforms therapeutic relationships and promotes true healing. And I learned a lot about trauma-informed care and all of its benefits. I believe that universalizing trauma-informed care that is also knowledgeable of differences in cultures is the best way that we can help people with CPTSD to get the care that they need. In conclusion, complex CPTSD provides a more complete framework for understanding the impact of chronic trauma than PTSD alone. Accurate diagnosis is critical to providing effective treatment and improving outcomes. Ongoing research and clinical advocacy are essential to continue moving this field forward. By continuing to refine our understanding of CPTSD, we honor survivors' lived experiences and advocate for real, effective healing. Here are the references for the sources used in this presentation, as well as the illustrations. Thank you so much for your attention.